Welcome everyone for the eve of Valentine's. So appropriate talking about our hearts. I'm Davidicus Wong, family doctor in Burnaby for over 32 years. And with me is Leona Cullen. So she's one of the project managers. Are you acting co-executive director?
Yes,
Yeah.
that's my title in this moment. Yeah.
Yeah, she's helped the division through a big transition to a new executive director. But she's always been there as the backbone of our Empowering Patients program, which is our public health education branch of the Burnaby Division of Family Practice, which is the nonprofit association of family docs working to improve the care of not just their patients, but everyone in the community in partnership with so many other um, nonprofits, as well as the health authority and the hospitals, and so many organizations that give their best and give their heart to all of our well-beings. So today's topic, I was going to give this title because it's so appropriate for Valentine's Day Eve. How can you prevent a broken heart? And but I won't be singing anything in falsetto. We're trying to give you objective information that you may not have heard before, and I have particular objectives that I'll share with you as well. But again, this is part of the Burnaby Division Public Health Education Program. And this recording is going to be available in a couple of days. Leona will work her magic. So you can go to the Burnaby Division website, looking up Empowering Patients, and you can find the recent past performances that we've done, video productions we've done, the little YouTubes that you can watch anytime, including this talk, and also the resources. So the slides that I'll be using, you want to go back to them, but also easy to refer to 1 or 2 page key point handouts that I put together as well. We cover a variety of topics, but it's really meant to give you the key information you need to stay healthy and how to talk to healthcare providers like doctors and nurses, how to get the best out of your hospital stay, how to be your advocate or how to be an advocate for your loved one. And we really want to promote health in our community. This is one of the tenets of our Empowering Patients program is that we were made to move. When we don't, our health suffers, but when we do, we thrive. And that's a picture of my dad. I think this is taken about 5 years ago, but he looks almost the same and he's about to turn 95 and he's still really fit and sharp in mind as well as body. So one of my examples is someone that looks after his own health, my dad. Um, so why are we here? We're here because we care about our loved ones. So this remind me that I'm dedicating this particular talk to my mom. So she passed away quite a while ago now. It was 2003 from a massive heart attack, and she had never had any known heart disease before. But she did have some risk factors like high blood pressure and mildly elevated cholesterol. So she was on blood pressure medication. But it was in those days where we didn't have blood pressure machines to use at home. It wasn't very common. Now there's a very accurate machines you can use to know that your blood pressure is well controlled. I remember her telling me one time after seeing her doctor, well, how is your blood pressure? And the doctor said told her it was so high she didn't want to tell her because she was afraid that my mom would get upset if it was too high. But my approach is that I want to keep the patient well informed, tell them about what I'm worried about, and empower them to take control of their health. So I dedicate this talk to the memory of my mom, who is a big part of the Burnaby community as well, and my inspiration for much of what I do in my work and in my life too. And my mom originally cared for her own family. She grew up in Strathcona area, close to Chinatown. And she was orphaned when she was just 9 years old, with her other siblings ranging from a 2-year-old to older teenagers, her older sisters. And the older sisters decided they would look after the family. Auntie Hazel would act like the mom, Auntie Mimi, Auntie Margie would go to work, and everyone did their part to support every member of the family till they all grew up. And we continued to meet every Boxing Day as a celebration of this family of kids that stuck together so they wouldn't be separated. And it's helped generations to survive and thrive. My mom's caring expanded not beyond her own family to friends, to the church community. And she's always doing volunteer work and just showing this expanding circle of care, much like um, family doctors do in their expansion of care, not just looking after their own patients, but now caring for the community through the primary care networks in the Burnaby Division of Family Practice. And of course, it was a big loss when I lost my mom. But what kept me going was knowing that my mom's greatest legacy was the love that she gave to me. And that's like all the love we receive, just like the water cycle, love is in us for to give to others to move that forward. So the best tribute to my mom is to give that caring to my kids and my wife, um, to all of my family, but also to my patients and all of you in the community so that I can provide to you things that will be a benefit and for your well-being. So you're all receiving the legacy of my mom. And as I said, family docs have shown they not only care about their patients, we care about our community. And together, all of us here and all of us in the community look after our future. So I'm going to invite Leona to share some key information about the Burnaby Division of Family Practice. She usually has some great resources that she can share in the chat.
Yeah, so thank you everyone for coming out tonight. It's as Dr. Wong said, we've been doing this for I think about 10 years now, and so I'm very honored to be a part of this program and to work with Dr. Wong for all these years and getting this important information out to you and to the rest of the community. So I've already sort of started populating some links in the chat, so check them out. The first one is our Empowering Patients page, which includes our schedule of upcoming talks and also recordings of all of our talks. So as Dr. Wong said, I'm going to actually try and get tonight's recording up later this evening, just so you can access it and share it tomorrow. I've shared the other resources page, which includes the links to Dr. Wong's presentations and the information sheets that he prepares for each topic that we share. So those are things you can download, you can print, again, you can share with folks, but it's really great information that Dr. Wong puts together. If you are looking for a family doctor in the province or in Burnaby, I'm putting the looking for a family doctor page in the chat, and that'll just guide you to the Health Connect registry, which is the provincial waitlist for family doctors. If you live in Burnaby and you identify yourself as living in Burnaby, then you will eventually be contacted by our patient attachment team, and hopefully they'll be able to attach you to a doctor or nurse practitioner. I've also, as Dr. Wong alluded to, Burnaby has done a lot of great things working with the Health Authority and with our community partners on pulling together resources and providing resources to the community and to Burnaby family doctors. So things are going quite well in recruiting doctors to Burnaby because we have a lot to offer for them and to offer their patients. So it's not difficult to be proud of working for the Burnaby community and the Burnaby division. So the Burnaby PCN, or Primary Care Networks, is highlights all of that great work. So you can check out that page. There's some social supports available for seniors, for youth, teens. So check it out. You never know, there could be something that would be a benefit to you. We do a monthly newsletter called The Checkup. So if you're not already subscribed, please do. There's a lot of vetted information on health and wellness and PCN, or Primary Care Networks, updates, and things about COVID. We still say, COVID is still a thing. So yeah, we have a team that puts that information together. So I'm going to put the February brand new hot off the presses issue into the chat, and when you go through, you read that, get to the bottom, and you can subscribe, and then you'll receive all of them. And I'm also going to put a link through to our next talk. We haven't even gotten through this one, but our next talk is What You Should Know About Healthy Eating, which is a good one. I love that one, and that's being held on March 13th. So I'll put the registration link in there, and you can sign up and we can get together in a month. So, and then the last thing I'll talk about is Walk with Your Doc has officially been scheduled for Saturday, May 17th. So perhaps we can all get together in person and go for a walk on a nice day. And that's it. That's all I have. If you haven't participated in these talks before, we do a short, very short, 8-question summary at the end, or a survey at the end, just to get some information from you on what you thought about the talk. So Dr. Wong and I review that every month after every talk. Your feedback is really valuable to us. So please take a moment to share. And that's it. I'm going to turn it back over to Dr. Wong.
Okay, thanks, Leona. Thanks for all you do for our community through the division and your volunteer work. And yeah, please save the date for our walk with your doc in May, because I'll be there and look forward to seeing you in person.
Exactly. All right.
Show that we walk the talk and we care about our community. So today I'll share a description of how the heart works, because you'd be surprised. We all have a heart, but most people don't really understand the different chambers of the heart, what the valves do, that the heart conducts electricity, and that's how we have coordinated heartbeats. And then what are the different types of heart disease? Because there's a lot of confusion. People might know that there's heart disease in their family, but knowing what type of heart conditions, that could be narrowing of the arteries or atherosclerosis that can cause angina or chest pain with exercise, or premature heart attacks, or is it heart failure, problems with the pumping action of the heart, or is it a rhythm problem like atrial fibrillation, or is it another heart condition involving the valves between the chambers of the heart? So I'll explain in straightforward layperson terms how the heart works and what these different types of problems are, so that you can identify the symptoms early, know what your risk factors are, and be able to modify those risk factors to perhaps avoid these conditions, but recognizing them early if they do arise, prevent them from causing complications or from shortening your lives or the lives of your loved ones. So my personal goal, of course, is that this information, what we talk about today with you in this room today, will save lives, yours or your loved ones, that is going to prevent heart disease in its many forms. And it'll help each of us recognize the different types of heart disease really early on, so you can get help and modify risk factors, and you can get the support you need to reduce future disability and to avoid premature death. Because that's what it's all about, a good quality of life, doing the things that you enjoy, being as fit as you can, and spending time with your loved ones while we're all here. So that's my personal goal. So I'm trying really hard. And a quick question, what is healthcare? Is it the stuff that doctors and nurses and healthcare providers do? Is it the stuff you see in the hospital or the stuff you see in the community? Well, really, when you think about the most important person, that's the one that's going to determine your health outcomes, is actually you, of course. Because no matter what doctors and nurses are instructing you to do, you're the one that has to do it. And you have to do that to achieve it, because that's your personal goal. We're here to support you, to give you expert advice, objective advice, but also give you the tools and the support and connect you to the resources that you need. So that's why I think real healthcare is that self-care, because you're the most important person that does most of your healthcare, 99% of it. And the best predictor of your future health are the habits that we practice every day. And in our talks, there's an overarching theme that I think of 4 foundations of looking after ourselves. What we put into our body, what you eat, what you do, physical activity, how you feel, emotional well-being, and how we connect, healthy relationships. So the 4 foundations of self-care: what you eat, what you do, how you feel, and how you relate. And those are some of the key topics in our previous Empowering Patients talks. But we also talk about how to communicate with physicians. And at the end of this talk, if there's some time, I'll give you some key tips when you're talking to a healthcare provider who might be recommending some medications or prescribing a medication or a procedure. What key questions to know, just to be an advocate for yourself and to get the information and care that you need. I've had talks on surviving your hospital stay, being your own advocate, and what things to watch out for to improve outcomes. And there's key information on the symptoms that might indicate disease, because and also the screening tests that we should do at different times of our life as well. and also key information on how to make positive changes in your life. So you can find all of these topics online, videos, handouts, and my slides themselves on the Burnaby Division site. So a quick primer on how the heart works. So the heart, about the size of the fist, just to the left of the sternum, the left side of our chest, we know it's a pump. It's pumping blood that's been oxygenated and enriched with oxygen from the lungs to the rest of the body, including your brain and your other vital organs, your extremities, your kidneys, your bowel. So your heart is that muscular organ, but what helps it do the careful pumping of blood from the lungs to throughout the body in a coordinated fashion is because it's also an electrical organ as well. It conducts electricity, it generates electricity. And the heart is made up of 4 separate chambers. You might hear that we talk about the right and the left heart. Those are 2 sides of the heart. Each side of the heart has a smaller chamber called the atrium, kind of like the attic. And then the larger chamber below is the ventricle. So the left side of the heart has the left atrium and the left ventricle, and the right side, the right atrium and the right ventricle. And between those chambers are the valves that prevent blood from flowing backwards in the opposite direction that they're intended to. So if you look at the diagram in the bottom right-hand corner, it shows you how the blood flows. So you can see that red blood has been blood that's rich in oxygen. So it's just passed through the lungs and it's enriched with oxygen that's going to provide some energy to the rest of your body. And the blue color is for deoxygenated blood. So that's blood returning through the venous system, through the veins, back to the right side of the heart, and then pumping through the right atrium and ventricle up into the lungs to be filled with oxygen again. So again, the right atrium receives blood from the rest of the body through the venous system, pumps that blood into the right ventricle, which then pumps the blood into the circulation of the lungs, where we load it up with oxygen. And then that blood returns from the lungs through the pulmonary arteries to the heart. And then the left atrium receives oxygen-rich blood from the lungs, pumps it into the left ventricle, which then pumps the blood to the arterioles throughout the rest of the body. So that's the nice bright red blood going to supply energy to every part of your body. And that heart muscle is electrical. So these 4 chambers of the heart have to be contracting in coordination. You don't want the atrium pumping the same time as the ventricle, otherwise the ventricle won't have that extra blood from the atrium at the same time. So the atrium has to contract, empty its blood into the ventricle, then the ventricle contracts, pass the blood to either the lungs or the rest of the body. And it's because within the atrium is a natural pacemaker. So you can see that SA node, or we call it the sinoatrial node in the right atrium. That is the natural pacemaker that sets the pulse rate, and it sends that electrical conduction through circuits within the heart muscle. So the heart muscle is electrical. That's why we don't stick our forks into electrical sockets. It might give a shock to your muscle, but you don't want it to give it a shock to the heart muscle and obliterate the normal conduction of electricity through the heart. And because of that electrical signal, that's why when we resuscitate someone whose heart has stopped, we're using defibrillators, electric current over the heart to restart the heart. And that's another way that we can actually pace the heart. And in fact, pacemakers they're the size of a cigarette lighter put underneath the skin, but they have leads that go into the atrium or the ventricle to give the signal for the atrium and ventricle to contract in a regular fashion. So pacemakers take advantage of that electrical nature of the heart itself. So are you at risk for heart disease? The answer is yes, all of us are. Because the risk for heart disease increases as we age. That's why our normal life expectancy is probably just to our 80s. And the most common cause of death, of course, at that age would be from a heart attack or from a stroke. because our blood vessels become narrowed, clogged with cholesterol, and a bit hardened from blood pressure over time. So these normal aging changes contribute to that increased risk for heart disease over time. Some other conditions that can make you even more likely would be a family history of increased risk, so premature heart disease. So we'll talk about particular conditions in the forms too. So although we can't control our age or the genetics yet, knowing that, so some people in the past used to, knowing that their father or mother died at a young age from heart disease, might just expect themselves to die at the same age of heart disease. And they think of it as like the family curse, and think pessimistically about their ability to avoid premature disease or death. But I like to think of family history as a gift as well, because it can make us more proactive in recognizing and managing the very modifiable risk factors that we can identify. And that includes our daily lifestyles. So the things that are within our control. Family history, depending on what condition is, can tell us what symptoms to watch out for and what particular things to watch out for. So a premature heart attack might be due to family history of high blood pressure or of diabetes or high cholesterol. So things that we can easily screen for and then modify early. So this does not include every minuscule type of heart disease, but these are the four major areas. When people talk about heart disease, it's usually one of these four. Number one being coronary artery disease. That means narrowing or disease of the blood vessels, the arteries that supply oxygen-rich blood to the heart muscle itself. So not the bigger blood vessels that are coming from the heart to the rest of the body, but those blood vessels that branch off the aorta that have been enriched with blood into the heart itself, supplying blood to that muscle. Because if that blood supply is cut off to a large portion of the muscle, the heart will stop pumping, even if there's electrical activity. And the second big group of heart disease is valvular heart disease. So when the valves that prevent the backflow of blood between the chambers of the heart, if they're really narrowed, then the blood doesn't get through. If they're weak and lax, then the blood goes backwards, what they call regurgitation. And then the blood isn't getting where it ought to and supplying oxygen-rich blood to the rest of the body. Arrhythmias refer to what people call palpitations, which people may or may not feel. So that could be extra beats, extra fast beats, extra slow beats, or it could be totally irregular heart rhythms. And then finally, the fourth main area of heart disease is heart failure. So that's when the heart is no longer pumping as strong as it can and getting that blood away from the lungs and towards the rest of the body. So when the pump failure, there's specific symptoms that by the end of this talk, you'll be quite expert on. So talking first about coronary artery disease. So again, the coronary arteries are the blood vessels that deliver oxygen-rich blood to the heart. And you can see in the picture in the bottom right-hand corner that aorta is the big blood vessel that's leaving the left ventricle. That's received blood from the left atrium. So this is oxygen-rich blood. And there are branches off. You can see the little red blood vessels coming off that big aorta on the top. Those are the coronary blood vessels, such as the right main coronary, the right anterior descending. So these are the major coronary arteries, and then they branch out to supply blood to all the muscle of the heart. And we need that good blood flow for the heart to continue pumping well. And if that blood flow is cut off, the muscle downstream from that artery will die if it doesn't get immediate care or a bypass or a stent. So when a coronary artery is completely blocked, that downstream muscle is starved of blood and actually dies. And that's actually what a heart attack is. I'll be going over the symptoms of a heart attack, which can be quite variable. There's the classic symptoms, and there's the not so classic or atypical symptoms that is really important to recognize. And it kind of explains why a lot of people, including women, are often not diagnosed soon enough when they do have heart attacks because they might present with some of those atypical symptoms. So in the case where the coronary artery is completely blocked and there's no flow of blood to the heart muscle, that's a heart attack. But there's some cases when it's not completely blocked, just partially blocked. So when that happens, the area of the heart muscle downstream receives less blood than it needs. And when the heart has to pump harder and faster, and that muscle is working harder, it demands more blood. And if the artery is narrowed, then that causes what we call ischemia, or decreased blood flow. And the symptom most people get when they have ischemia is called angina, which refers to pain in the chest. So the typical symptoms of angina would be when I'm doing exercise or when other things make my heart beat fast, like being scared or super anxious. When my heart beats fast, then I get pressure or pain in the chest. And when the heart slows down, when I stop exercising, or when that stress is gone and the heart's returned to normal rate and the pain goes away, those are the classic symptoms of angina. So this is kind of a little illustration of those arteries. So a normal coronary artery doesn't have this gunk called plaque inside of it, but with atherosclerosis that happens with age and is accelerated by damage to the walls of the heart through cholesterol deposits or blood clots or high blood pressure over time. There's some narrowing. And then if you have a narrowed artery and then a blood clot clogs that small opening, then you can get a heart attack. So the classical symptoms of a heart attack, also called a myocardial, that means heart muscle, infarction, which means death, or MI. The classical symptoms are a squeezing pain in the chest, either central behind the breastbone or sternum, or to the left. It can present at those similar symptoms like an ache or pain or pressure in the throat or in the arm. Typically we think left arm, but it can be either arm. But that pain is actually caused by ischemia here. It's actually, the pain is referred into the throat or either arm. Often with a heart attack, people feel really nauseous. Sometimes it's mistaken for heartburn because you feel really queasy and sick to your stomach. Often someone will break out into a sweat, often a cold sweat as well, because that's the nervous system responding to that severe visceral condition of a heart attack. And typically shortness of breath at the same time, because if the heart's not pumping that oxygen-rich blood to all your organs, you'll feel that deprived of oxygen as well. So these are the classical symptoms: chest, throat, or arm pain or pressure, sometimes described as squeezing, nausea, queasiness, stomach upset, sweating, or difficulty breathing. And often there's a natural tendency just to grab your chest. So if you're seeing someone in public, grabbing their chest, looking distressed, looking anxious, having difficulty breathing, all sweaty, please go to them, come to their aid, be ready to call 911. So as opposed to symptoms of a heart attack, the symptoms of angina or cardiac ischemia or decreased blood flow through those arteries to the heart muscle are very similar. So it would be chest, throat, or arm pain or pressure that's worsened by, as I mentioned, things that increase the heart rate, either anxiety or physical activity. So sometimes when we ask patients, does the chest pain come on when you're anxious? We're not thinking that it's in your head, that it's some kind of just an anxiety attack and there's no problem with the heart. We're asking because that could be a symptom of poor blood flow in the heart because the heart beats faster when we're anxious. So chest pain or pressure that we feel with anxiety or physical activity because that increases the heart rate and demand of the heart muscle. So the important message, though, is not only to recognize the classical symptoms of angina or decreased blood flow to the heart muscle, or a heart attack, which is a blockage of blood flow to the heart muscle. So silent or atypical ischemia or heart attacks, The symptoms are more common in women, and it's more common in people with diabetes because the nervous system in diabetes can be altered as well. So this kind of summarizes the difference between typical men and women. So men might feel that typical chest pain, squeezing chest pain. Women might just feel pressure or nothing at all in the chest. It can present as a rapid irregular heartbeat, feeling dizzy and faint. That could be the case with women as well. Or it could be more subtle, like just feeling unusually exhausted and fatigued for several days, maybe even a week or longer after a heart attack. Sometimes women describe just the feelings of anxiety and disturbed sleep. And it's not in their head, it's actually for them that could be the symptom of ongoing or recent heart attack. So the pain can be also felt in the back, in the neck, in the jaw, either of the arms. It can be nausea in either gender and often shortness of breath in men and women. But just recognize it may not be that classical chest pressure or shortness of breath, that it can be just exhaustion, feeling a little bit worn out, feeling out of shape, really a vague type of anxiety or insomnia, really subtle symptoms that don't always, to the average person, they wouldn't think about a heart problem. So again, quick summary. So often in men, but not all men, so men with diabetes might get atypical symptoms, that chest pain or discomfort, that can be throat or arm, feeling dizzy, faint or lightheaded, a cold sweat, stomach discomfort, and shortness of breath. And in women, it can be that chest pressure, but it could be felt in the back, the arm, the neck, or the jaw. Women can be presenting with extreme exhaustion for several days, anxiety or disturbed sleep. They can get some nausea or stomach upset. So it can be mistaken for heartburn in so many people. But usually shortness of breath, doing your physical activities like walking up the stairs or doing household activities. So narrowing of the arteries or atherosclerosis can occur in the coronary arteries, but it can occur in all the other arteries. So we were just talking about symptoms when it affects the arteries supplying blood to the heart muscle, the coronary arteries. But when you get the same process, narrowing of arteries to your extremities, like to the calf, to the leg and your foot, the symptom of ischemia in those cases would be when you're walking, you'll get this terrible pain in the calf, one or both calves, depending on which side has the blockage in the arteries. And then when that person stops, the pain goes away. When they start walking again, then the pain comes back. So that's not just a sore muscle. That is the classical symptom of what we call claudication, or narrowing of the arteries that are supplying the legs, the calf muscles. So people that are at higher risk for peripheral vascular disease or this poor circulation to the extremities can also have the same process in the blood vessels going up to the brain, to the abdomen, and to the heart itself. I have some patients that simply present with severe abdominal pain when there's increased blood flow, such as when they're exerting themselves or after a big meal, because the intestine, what we call the mesenteric circulation, requires extra oxygen so they can digest your food. So sometimes abdominal pain with exercise, so terrible abdominal pain with eating a big meal may not be actually anything wrong with the intestine, but rather the circulation in the intestine. It's the same risk factors that we'll describe in a moment that affect narrowing of the arteries in all parts of the body. So if you have narrowing of the arteries to the circulation to the brain, for example, the vertebral arteries in the neck or the carotid arteries in the front of the neck, the symptoms could be a stroke if an artery is completely blocked, and a stroke is where there's death of brain tissue that are supplied by a particular artery, or transient ischemic attacks, where it's like angina, you temporarily get the symptoms of weakness or loss of sensation on one side of the body or the face. That comes back within 24 hours. You can get a blockage of blood supply to a portion of the back of the eye, the retina. And this can be a cause for blindness as well. So it's called a retinal artery occlusion. We've talked about peripheral vascular disease where you get the calf pain with walking, but a lack of blood supply supplying the kidneys can lead to kidney failure. And that can occur without any kind of pain, but a decrease in the function of the kidneys and decrease in production of urine. So for all these forms of narrowing of the arteries supplying blood to your precious organs and all your muscles, the risk factors are common. They are high blood pressure, which we can modify with lifestyle as well as effective medications, highly hereditary, diabetes, so recognizing it early and doing the lifestyle changes, managing weight, and taking medications appropriately to control the blood sugars and keep them in the optimal range. That can reduce the progression of atherosclerosis. High cholesterol, particularly high saturated fats that get converted to the LDL cholesterol. They create plaque that closes up or narrows the arteries that can cause angina, heart attacks, strokes, and claudication in the extremities. The family history. And the family history usually unveils either a congenital heart condition or narrowing of arteries or a valvular condition. But in the case of atherosclerosis, it often is related to hereditary high cholesterol or high blood pressure or diabetes. And of course, smoking is a major atherosclerotic risk factor, particularly not only with heart attacks and with strokes and kidney disease, but significantly with peripheral vascular disease. And this can lead to amputations of toes or feet or even entire legs. So let's talk about those risk factors and what we should all do as adults. So even if you don't have a family history of high blood pressure, pretty well all adults should check their blood pressure annually. So before the pandemic, that was pretty easy. When I saw a patient who hadn't checked their blood pressure in the past year, then we would check it when we see them in the office. But a good portion of family practice visits are virtual, not giving us an opportunity to just check the blood pressure while we're checking something else at the same time. So it is useful for, if you haven't had your blood pressure checked, you're over 30 years old, the older you are, the more important it is to make sure you do know what your blood pressure is. So some people just use the pharmacy, but we sometimes get crazy high or low readings at the pharmacies. It depends on the pharmacy and how often their machine gets calibrated. So ask the pharmacist if they are checking their machines or calibrating them to make sure they're accurate. Now, blood pressure machines can be quite inexpensive, like ranging from $50 to over $110. But good, reliable electronic machines that wrap around your arm, just press a button without needing a stethoscope, and they can give you a fairly accurate blood pressure reading. When my patients are relying on their home readings to screen for high blood pressure, to know that we're treating their blood pressure appropriately, I prefer that they bring or leave their machine with me overnight so I can check it against our gold standard, which is the mercury or aneroid sphygmomanometers that have been calibrated to be accurate. So when we know the machine is accurate, then I can rely on their home readings for checking regularly. When they're diagnosed with blood pressure, we're treating it with medication or exercise, or if they have a family history of high blood pressure, they can be checking it at home and see the influence of medications or exercise or diet. The particular diet that's good for lowering blood pressure is low in sodium or salt and low in alcohol, which increases blood pressure. That's high in healthy fats like omega-3s and 6s, fish, nuts, and seeds are generally good, and low in saturated fats like in red meat, like beef, lamb, or pork, or high-fat fast food, convenience foods, and snack foods tend to be high in cholesterol and salt. So the other risk factor is diabetes. So if you have a family history of diabetes, if you are overweight or a history of gestational diabetes, you're probably at higher risk for diabetes. And we would recommend that you do screening. There's a simple screening called the hemoglobin A1C, People can also do a fasting blood sugar. And if either of those are elevated, then the glucose tolerance test, which takes a couple hours. People with diabetes are considered to have an over 20% 10-year risk for a heart attack. It means just having the diagnosis of diabetes is considered a major risk factor for coronary artery disease already. The other risk factor for atherosclerosis, narrowing of the arteries, is high cholesterol, particularly high LDL cholesterol, which can be treated with diet, exercise, and medication. And family history, a first-degree relative, that would be a sibling, a child, a parent, a mother or father who had premature heart disease, for example, under age 65. If your loved one first presented with heart disease or had a heart attack in their 80s, then that's not considered premature. But it's useful to know if they had risk factors that you might share that you can modify at a younger age. And of course, smoking, a major risk factor. In most cases, actually, more important than most of the others. And that's something that's very modifiable, but with support. And that's just a reminder of free support through provincial government, quitnow.ca. So people that register with that program, those smokers can get a free trial of nicotine replacement therapy, including the patches or the gum or the inhalers. So if you're a smoker and your resolution is to quit smoking, but you haven't got to that point yet, check out quitnow.ca. So how do we test to confirm coronary artery disease? So someone presents with chest pain or they have a family history and they're getting more shortness of breath. They haven't had a heart attack yet, but they've been getting lots of squeezing, pressure, nauseas, feeling more short of breath with exercise. So the first thing would be an electrocardiogram. We call it an ECG, electrocardiogram, or EKG, using the German cardiogram with a K. We sometimes say EKG, so it's not confused with EEG, which is an electroencephalogram, which are electrodes on the head, often used for screening for epilepsy. An exercise treadmill test that's done when someone is exercising is called an exercise treadmill test or a stress test. And when people are doing that one, we are monitoring their blood pressure as well as doing electrocardiogram live. The MEB is a nuclear test, doesn't use a lot of radiation, but it uses a little tracer that will show the blood flow in the heart, and then looking to make sure there's even blood flow to all the essential muscles of the heart. There's the CT angiogram and there's the angiogram. So I'll give you examples of each of these. So an electrocardiogram, so the 12-lead electrocardiogram is really helpful. It's kind of the gold standard. But if someone has a heart attack, like an old heart attack, like more than a few days old, we'll show some typical waves we call Q waves on the electrocardiogram. But if someone is having angina, but at the moment they're doing the electrocardiogram, they're not exercising and not feeling that chest pain, the EKG may be totally normal in between. Hence, we would actually go on to the exercise treadmill test. So the exercise treadmill test is about 70% sensitive to picking up coronary artery disease or narrowing of the blood flow in the arteries supplying the heart muscle itself. So it's called the ETT or stress test, exercise stress test. Often done, can be done on a bike, but often done with a treadmill. You can see that it requires someone to be mobile and able to walk. So it's very difficult with someone that has a disability or hip or knee arthritis. The nuclear stress test uses a scanner. You get a little injection with a low dose of radioactive material, a tracer that will show how blood is flowing to the different areas of the heart. So that one is more sensitive, not 100%, but 90% sensitive for picking up a problem. And then there is the CT angiogram. So that's a CT scan with dye injected so that you can actually see the arteries and see if there is narrowing of the arteries, so the CT angiogram. These are much harder to come by. They have to be ordered by the specialist, cardiologist, or intern. And the angiogram is actually dye injected into the arteries so that we can physically see if the artery is narrowed. So how do we treat coronary artery disease? Like we identify a blood vessel as narrowed or blocked in the case of a heart attack. So if we can get to it soon enough, then we can save the muscle that's downstream. So if there's a critically narrowed artery, like 90% narrowed, causing symptoms, we often do a procedure. The interventional cardiologist will do an angioplasty. So they'll insert a catheter through the blood vessels into the heart, and then they can see where a blood vessel is narrowed on the angiogram. They can see how far it's been narrowed, and if it's a short segment, they can insert a metal stent, not a stent, a metal stent, just to keep things open. And some of them contain medications that will prevent clots from forming inside. And some of them are just a bare metal stent. Another intervention, if it's a long stretch of the coronary artery that's blocked, then there won't be any stents that are long enough that they can open that whole area. So sometimes we bypass the plugged area like a detour. So a vein is taken actually from the inside of the thigh and the calf of one side, typically the left side. That vein is taken out from that individual getting the bypass. And if there's an artery that's narrowed in one portion of the heart, that vein was grafted on to the surface of the heart so that the blood can bypass the blocked area and then come back and then supply the heart muscle. So that's what a bypass is. And if someone has 3 arteries that are bypassed, then that's called a triple bypass. And if someone has 4 areas that were bypassed, that's called the quadruple bypass. So that's what people mean when they have bypass surgery. It means that a section of the coronary artery was blocked. Sometimes the coronary artery disease is diffuse, and we can only treat it with medication. So these medications control blood pressure, prevent blood clots from blocking a narrowed artery, lower cholesterol, condition the lining of the blood vessel, the endothelium of the blood vessel. So there's a number of medications to treat those. And we treat other risk factors as well, like such as quitting smoking, which damages the interior of our blood vessels and promotes accelerated narrowing of the arteries. Now, if you suspect someone is having a heart attack, either the classical symptoms of squeezing chest pain, sweating, nausea, shortness of breath, maybe palpitations, looking really unwell or pale, you call 911. You don't wait until trying other things, giving them oxygen, getting them to lie down. Call 911 because if it's a heart attack, a blood vessel is blocked, the sooner we can identify that and unblock the artery or take blood thinners, that those few moments, the minutes, can save heart muscle. So if we save time getting the care they need, then that can. So when you call 911, you would tell them that suspected heart attack, and they send the appropriate ambulance as well. So we're moving on to the next type of heart disease, which is valvular heart disease. And just remember, I mentioned that the valves are these kind of like one-way structures that just allow blood, when functioning well, to flow from one chamber to the other only in one direction, so it doesn't backflow. We also have little valves in the blood vessels in our legs, in the veins, that prevent, because when blood is returning back up to the heart, after we've been running around, we don't want that blood to stay pooled in the leg. So the valves just, once the muscles move the blood further up in the leg, then the valves keep it from flowing back down again. But in the heart, there are much larger valves. There's the mitral valve, pulmonic valve, tricuspid, and the aortic valve. And they separate the chambers, atrium and the ventricle, and the bigger blood vessels supplying heart to the lungs and the rest of the body. So you can see blood passing from the left atrium, this is oxygen-rich blood, to the left ventricle, on the right side of the diagram, which is the left side of the heart, that passes through the mitral valve, mitral. And then the blood flows from that right ventricle up into the aortic valve to the big aorta and the rest of the body. But it's the aortic valve that keeps the blood from flowing back from the aorta into the ventricle. And then when blood returns from the lungs, it enters the right, or when the blood returns from the body, it enters the right atrium. And it's the tricuspid valve that prevents the backflow from the right atrium to the right ventricle. And then blood is pumped from the right ventricle into the pulmonary artery, and it's that pulmonary valve that prevents the backflow back into the ventricle. Okay, so the mitral valve and the tricuspid valves are between the smaller and larger chambers, the atrium and ventricle on each side, and the pulmonic and aortic valves just prevent backflow into the pulmonary circulation or the aortic circulation. And a valve can either be narrowed, what we call stenotic. For example, mitral stenosis is narrowing of the mitral valve, so blood can't get through as quickly. And a valve can be incompetent. That means floppy and allowing the backflow. So if you have a tricuspid valve that's allowing the backflow of blood from the ventricle back into the atrium, that's called tricuspid regurgitation. So valves can be narrowed, or it can be floppy or incompetent. And then the names of a narrowed valve would be a stenosis, and a floppy valve that causes backflow is regurgitation. So you can see here's a little diagram of the aortic valve, and a common condition is aortic valve stenosis. So you can see the opening on that right upper photo that shows that the aorta is narrowed either due to calcium or fibrosis. So blood is not flowing well enough into the aorta, and that can cause shortness of breath and tiredness. It could even cause chest pain. And there's a typical sound that we can hear when we're listening with our stethoscope that can give us a clue that it's aortic stenosis. Yeah, and as I mentioned, usually it's due to calcification that can occur with age. Most aortic valves have 3 parts to it, or 3 cusps. So it's called the typical tricuspid valve. Some people have just a bicuspid valve. It's kind of hereditary. So the bicuspid valve is a little bit more prone to disease such as stenosis. So you can imagine aortic stenosis because there's decrease in that flow of blood out of the oxygenated left ventricle, that you're going to get shortness of breath on exertion, chest pain, and you might even pass out because blood's not getting up into the arteries, into the carotids, to the brain. And aortic stenosis progressively gets worse over time. So if you've been diagnosed at one point with aortic stenosis, make sure you get regular echocardiograms or ultrasounds of the heart. So the symptoms of a problem with a valve in the heart can be chest pain, tiredness or fatigue, shortness of breath when you're doing physical activity. And with these symptoms, the doctor might listen to your heart and hear what we call murmurs. That's a flowing sound we can hear at different areas of the heart. And we can diagnose which valve it is based on the location over the chest and also the characteristics of that murmur. Does it occur when the heart contracts, what we call systolic or systole, or does the noise or murmur appear when the heart is relaxing? We call those diastolic murmurs. So diastole is when the heart relaxes. And then when the gold standard for diagnosing a problem with a valve is echocardiogram, an ultrasound of the heart, very non-invasive. So we have specialized ultrasound technicians in the hospital that place a probe over the chest, and on the screen, they're able to isolate and do measurements and show how the valves are functioning. So we treat valvular disease by monitoring their severity with echocardiograms. And in a symptomatic patient that's becoming more short of breath, getting more chest pain, and shows progression and critical narrowing or regurgitation through a valve, then that valve can be replaced with surgery. And there's different ways surgery can be done based on the valve and the patient's condition. And with certain types of valve replacements, patients need to be on preventive antibiotics because certain types of valve can, for example, a mechanical heart valve, bacteria that can get in the bloodstream, like after you have dental work or certain other surgical procedures, can seed in the blood and then plant right onto portions of the valve, causing infection of the heart muscle itself, called endocarditis. So typically, if someone has an artificial heart valve where they need preventive antibiotics, when they see the dentist, they will take amoxicillin a certain dose before the procedure to prevent disease in the heart from bacteria passing from the mouth into the blood vessels during the procedure. Now, the third type of heart disease are rhythm problems. So an arrhythmia is an abnormality in the rhythm of the heartbeat or the contractions. So a heart rate that's too fast is called tachycardia. A heart rate that is too slow is called bradycardia. So classically, we'd say that a normal resting heart rate is 60 to 100 beats, and that tachycardia would be greater than 100 at rest, and bradycardia would be under 60 at rest. Don't panic if you have an electrocardiogram and it shows bradycardia. Look at the heart rate. Often if it's like 58, 59, it would be, say, bradycardia, but that's quite common and typical and no problem. And of course, our heart rate does increase with exercise. So my resting heart rate's usually between 50 and 55. That would be considered bradycardia, but it's actually normal. So people that do a lot of cardiovascular activity and they have a lot of endurance, typically we have conditioned the heart so that the heart rate is slower. But there are some inherited conditions or non-inherited idiopathic conditions where the heart just has a naturally slow heartbeat or the pacemaker is naturally slower. So sometimes those are monitored very carefully to make sure the heart rate is not so slow, like below 30, that someone's going to faint because the blood pressure is low. Premature beats are beats that come earlier than they should, and pauses are delayed beats. So ventricular fibrillation. So you remember there's the atrium, which is the small blood vessel, and the ventricle, which is the large chamber in the heart. So when the ventricle is not beating regularly in its normal rhythm and coordination with the atrium, but rather fibrillating, like quivering like that, that's a problem with the electroconduction is not coordinated. And if the big ventricle is fibrillating, then it's not going to pass blood into the aorta to the brain and the rest of the body. So in ventricular fibrillation, that can't last too long before you actually pass out and faint. And that can be a fatal rhythm. So ventricular fibrillation is generally treated with the electrical defibrillators. That's where they call defibrillators that you see at the community centers and our hospitals as well. So the two pads we put on the chest, the bare chest, and the individual will be shocked at particular setting for the joules or electrical intensity in the right places. And then electrocardiogram that's done at the same time will show if someone gets out of the ventricular fibrillation back to the normal sinus rhythm. Atrial fibrillation is a much more common condition, and a lot of people have no symptoms at all. So it's not unusual that I'll be checking someone's blood pressure and notice that the heartbeat is irregular, but not only is it irregular, like a skipped beat, but we find that it's irregularly irregular. There's no pattern to it at all. It's just kind of beating totally at random. So it's not 1, 2, pause, 1, 2, pause. It's just totally unpredictably irregular. So when I was at Eileen Daly Pool, I was in the hot tub. A young guy just came out of the steam room, and he was, of course, in there with a bunch of seniors. And he knew I was a doctor, and he asked me a funny question. He said, "Why does our blood get thick as we get older?" And I said, "That's a funny statement. Our blood does not get thick when we get older. Who told you that?" And he said, well, I was just in the steam room with all these old men, and they're all on blood thinners, which are anticoagulants like Coumadin or apixaban. So they're blood thinners that are used when someone has atrial fibrillation. So I explained to him, people with atrial fibrillation, because the little chamber of the heart is quivering and not emptying all its blood, that blood that's not moving can clot. And if the atrium that has a clot suddenly contracts, that clot goes into the ventricle, then goes up the aorta and can go up the carotid and cause a stroke. So people with atrial fibrillation are at increased risk for blood clots in the heart that will go up into the brain and cause a massive stroke. So that's what we want to identify it early. So if I feel that irregular pulse, or the people as individuals have had a stroke and we're looking for a cause, we often will do a monitor to pick up for atrial fibrillation. And a lot of our smartwatches, our Garmin's and Apple Watches, actually have built-in apps to diagnose atrial fibrillation. So I don't know if you can see let's see if you can see my Apple Watch here, but when I put it on an app, so I've actually used it in the office like dozens of times to diagnose atrial fibrillation. I would put it on my patient's arm, start doing an electrocardiogram. It just takes 30 seconds. Wondering if you can see that. Doesn't look countdown, but you can see it does a nice EKG tracing. And it's not going to show atrial fibrillation, but I can interpret that rhythm strip and get an idea if the patient has atrial fibrillation or another form of arrhythmia. Yeah, and then that gets sent to my watch and I can print out a PDF. So a lot of patients have devices in the watch and they come in because their watch has told them that they have atrial fibrillation. In fact, my brother-in-law was diagnosed with atrial fibrillation because we were fooling around with my sister's Apple Watch and showing him how to use the EKG. So sometimes people have no symptoms, but some people have fainting spells or shortness of breath or catching in their breath or notice that their pulse is irregular. So anticoagulation is taking those, what the young man said, are blood thinners. They're much stronger than aspirin. The examples are Coumadin or warfarin or Xarelto, apixaban. So they reduce the risk for ischemic strokes from blood clots, but because they're very good at preventing the blood from clotting, they can increase the risk for hemorrhagic strokes or bleeding in the brain and for gastrointestinal bleeding. So with each person, we have to look at their risk factors, even if they do have atrial fibrillation, to see if their risk for having a stroke with atrial fibrillation is exceeded by the risk for a hemorrhage or a gastrointestinal bleed. So it's based on age and other risk factors like high blood pressure. As I mentioned, we do a scoring system to advise if it's in their favor to take blood thinners, but generally as we get older, there's a higher risk. We also treat other arrhythmias with pacemakers. So as I mentioned earlier, pacemaker is like the size of a just a little pack that goes underneath the skin. It has two leads that go in the atrium and ventricle. It actually has a battery that can only be replaced by actually removing the pacemaker as well. So the pacemaker is not in the heart. It's in the skin, in the chest wall, either just on top of the muscle or just a little bit deeper in the tissues. But the leads actually go into the heart and then to the atrium and the ventricle. So they can prevent the rate from going too slow or going too fast. And some of them actually have built-in defibrillators so that if you go into, if the heart stops or if you're going to ventricular fibrillation, then it'll give a big kick of electric current and defibrillate the individual. And there's also a procedure called catheter ablation, which is done by very specialized interventional cardiologists. So in the lab, the electrophysiology lab, they can insert a catheter into the blood vessels, typically through the vein, and they can reach the pacemaker or the atrium and looking at the aberrant pacemaking tissue that's causing electrical currents. So what they do is they identify the circuits and they're able to burn out or create scar tissue on the walls of the atria to block those irregular electrical pathways. So actually, I had a very young patient that had that procedure just a short while ago with great success. So what are the symptoms of arrhythmia? As I had mentioned, there's a lot of people that have no symptoms and we just pick it up in the office. But the person might have chest pain. They might have intermittent shortness of breath. They might notice palpitations that come and go, or they might have frequent fainting spells for no reason. Because when you have an irregular rhythm, it could be so fast or so slow that the blood pressure drops and blood doesn't get to the brain in the same quantity. So someone feels faint and passes out. But as I mentioned, some people have no symptoms at all. So definitely something that cannot be diagnosed by telehealth unless the patient has equipment like an Apple Watch or another device that you can use to detect your heart rhythm, like called Cardia. So to detect arrhythmia, there's the electrocardiograms, EKG or ECG. A Holter monitor is a monitor you wear for 24 hours. But sometimes an arrhythmia like atrial fibrillation could be so infrequent or paroxysmal that often the cardiologist will get a 2-week event monitor that the individual carries around for 2 weeks and then presses the button when they're getting symptoms to catch the arrhythmia. And then often we will do an exercise treadmill test because the stress of exercise at higher heart rates might bring out an arrhythmia, irregular rhythm that we might not find when someone's just resting, as with the EKG. And now we're down to the fourth major area of heart disease, heart failure. And as I mentioned earlier, the heart is a muscle, and its purpose is to, aside from warming your heart when you're with your sweetheart tomorrow on Valentine's Day, it pumps life-preserving blood to every part of the body, every organ, every muscle, including your brain. And heart failure is a decline in the normal ability of the heart to pump the same amount of blood. So we have something called the ejection fraction. So an ejection fraction of 60% is kind of fairly normal. How much of the ventricle, left ventricle is emptying with each contraction. So that can be measured on the echocardiogram or the maybe MPI scan people do in that hospital exercise test. But sometimes damage to the heart muscle or enlargement of the heart for various means, we'll talk about the causes, the heart doesn't pump as much, and that's called congestive heart failure. So there's less blood flowing from that left ventricle to the organs of the body and to the muscles. So the symptoms of heart failure include fatigue, shortness of breath when you're exerting yourself, like walking up the stairs or carrying the laundry or walking uphill. Shortness of breath when you're lying down, because if the blood is not pumping blood away from the lungs to the rest of the body, then blood can pool and back up into the lungs themselves. So when we're lying down, we're short of breath. When we're upright, that blood is emptying from the lungs. So some people might wake up in the middle of the night short of breath and they have to sit up and it settles down, and they lie down and shortness of breath comes back. So that's a typical symptom. We call it orthopnea or nocturnal dyspnea, shortness of breath. If the heart's not pumping, blood accumulates in the extremities, we get swelling in the feet and the legs called edema. So there's other causes for edema as well, such as varicose veins. Sometimes we see that if you have excessive sodium. But sometimes it's because that blood is not being pumped appropriately by the heart, so it's backing up into the legs. And when you're retaining all that fluid in your tissues, you can gain weight. So a 5-pound weight gain in a day is probably not from going on an all-you-can-eat restaurant binge, but it can be from retaining fluid because the heart's not pumping enough. You're in heart failure. Or a 10-pound weight gain in a week would not likely be just from food, but unless you're on a cruise, but it can simply be that water weight. So that's why people with heart failure are asked to weigh themselves on the bathroom scale every day and to keep a log so they know if they need to take something to get that fluid off. The most common causes for heart failure are high blood pressure over many years, or coronary artery disease, narrowing of the coronary arteries, because they supply blood flow to the heart muscle, and if it's not getting there, or you've had a heart attack, then the heart muscle is not pumping as efficiently. But there's other causes. So people can go into heart failure with atrial fibrillation or other irregular rhythms because the heart's not contracting, the chamber's not contracting in a regular way, so blood is backing up and you're not having the normal ejection or emptying of the left ventricle. Smoking is a common cause that not only narrows the blood vessels in the heart and elsewhere in the body, it damages the heart muscle itself. Obesity causes lots of extra work for the heart, trying to pump blood through the resistance throughout the whole body, and it can exhaust the heart. And thyroid disease, either over or underactive thyroid disease, can overstress the heart as well. Over time, alcohol has a direct toxic effect on the heart muscle. It causes what we call alcoholic cardiomyopathy. And there are other forms of heart muscle disease, cardiomyopathy, that can be hereditary or can arise de novo. And sometimes they result from medications, such as medications that are used to treat cancer. Less common causes could be a viral infection, so some virus that affects the heart, like COVID, the heart muscle. So sometimes a virus can cause endocarditis, like damage to the heart muscle itself, and then resulting in heart failure. Again, it could be the side effects of medications, or it can be due to metabolic conditions, like the thyroid itself, or forms of diabetes or prediabetes, or conditions that deposit iron into organs, such as hemochromatosis, where iron can be deposited into the heart muscle and cause ineffective heart muscle contractions. So heart failure is treated with controlling the causes to prevent further damage by controlling blood pressure, treating the causes for atherosclerosis, and treating diabetes to target. That means getting the sugar levels and the cholesterol levels to areas that will reduce the progression of disease. Unfortunately, it takes many years of high blood pressure to cause heart failure, and often by that time, some of the change is irreversible. That's why we want to identify symptoms early, or actually just identify and treat risk factors like high blood pressure, which is so silent. So hence the importance of all adults checking their blood pressure fairly frequently, at least every 1 to 2 years. We also treat it with a low salt diet because salt can increase the retention of water as well, and make things more difficult. So we try to avoid excessive alcohol because that damages the heart itself. We want to quit smoking, which has a direct effect on the blood vessels as well as heart muscle. And we use a variety of medications, such as beta blockers like bisoprolol, or ACE inhibitors like ramipril, and diuretics like Lasix or spironolactone. So these have been found in many, many studies to improve the contraction of the heart. So a combination of these medications, so people are sometimes surprised getting a diagnosis with heart failure, then suddenly being put on 4 new medications. People can get pretty shocked and surprised, but many of them feel quite a bit better once they get the right dose of these medications. And of course, treating reversible causes like an overactive thyroid, or treating an anemia that's making the heart beat too fast, or treating the arrhythmias like atrial fibrillation. So self-care that we've been talking about at the beginning is the key to reducing your risk and improving your life. Yeah, improving your life itself. So not only preventing premature death or disease, but also improving the quality of your life and allowing you to be active and feeling well. It's really important to know how to monitor yourself, knowing how to monitor your blood pressure, report regularly to your physician, recording your daily weight, and we would usually tell you at what point you need to take an extra diuretic to take off extra fluid if you increase weight 5 pounds in a day from water weight. to understand what each of your medications is for. So I'm happy to explain to patients. Usually when I prescribe medications, I explain to them carefully what it's for, including the risks and benefits. And I'll give you some tips if we have time at the end on the key questions to ask healthcare providers about what they're prescribing to you or recommending to you. And for chronic conditions like diabetes, as well as heart failure, um, coronary artery disease, um, it's useful to have a support group, and that usually includes um, clinical nurses, nurse practitioners, dietitians, exercise coaches. So you can not only manage the particular symptoms of that condition, but also to partake in healthy eating, healthy physical activity that's appropriate for your diagnosis and your condition. Okay, I think we do have time. So bonus, um, patient-doctor communication. When I talk about patient-doctor communication, you might notice it's usually called doctor-patient communication, but rightfully it's the patient first. Listening to the patient, understanding what their needs are, what their questions are, providing information that the patient will understand, not just doctor jargon, and the opportunity for the patient to ask questions so they can know if the treatment we propose is appropriate to them, and giving the support and knowledge so that they're able to make the choices in an informed way. So what should you know about every treatment, prescription, or investigation? So before any cardiac test or any test or blood test the doctor sends you for, with any prescription the doctor writes or any vitamin he recommends or she recommends, or a treatment like a pacemaker or surgical treatment, these are the key questions. Number one is, what is that procedure, prescription, or test for? So what is the thing you're looking for? Is it you're looking for identify thyroid disease, um, to confirm diabetes, to look for risk factors for heart disease? So what is that test for? What was this medication for? What are the common risks or side effects of that medication or treatment or the test? And then what are the major risks, even if they're infrequent, or major side effects? So things that may not be pretty rare, but something you'd like to know about. For example, a common vaccine that people over 60 are getting is the Shingrix vaccine. It's a two-part vaccine, so given initially and then given 2 months later. It's quite expensive, but very effective. 90% effective in most people for preventing an attack of painful shingles, which is called herpes zoster. So it's a recurrence of the chickenpox virus across one nerve, and it could be extremely painful. So a lot of people would like to avoid that by getting the Shingrix vaccine. So its indication is for prevention of shingles. So we could talk about how effective it is, but there's still a chance it may not work for an individual. Second question is, what are the common side effects? So the common side effects of this vaccine will be pain at the injection site, sore arm, maybe flu-like symptoms for a day or so, sometimes fever, like immune response. And those things are more common than with Shingrix and most vaccines because it has something called an adjuvant. That's why it's so effective. And the adjuvant boosts your own body's immune response to what we're injecting into you. So the major risk is a strange autoimmune condition that can cause diffuse muscle weakness that can last a long period of time. It's extremely rare, but we do need to mention it because that might be a reason you might decide you wouldn't want to risk it or take that chance. And then what are the alternatives? If I don't get this vaccine, are there other things that can protect me? Or what should I do if I'm not vaccinated? What are the symptoms I should watch out for shingles? So if you get this funny type of pain, side of your face, one arm, one leg, side of your body, only on one side, the pain comes first. It could be burning, tingling, like nerve type pain, and sensitivity of the skin. And then a few days later, probably less than a day, a week later, you break out in a rash, initially red, and then little bumps, like little blisters that look kind of like chickenpox, but just in one part of the body. So you would want to see a healthcare provider within 72 hours of seeing that rash that came along with that pain to make sure it's not shingles and to take an antiviral pill that will lessen your chance of having permanent pain from from that attack of shingles. So that's the only alternative. There aren't any other effective vaccines. So for every drug you're given or prescribed, again, what is the indication? What is it for? What are the potential interactions with either food or other drugs or vitamins? What is the brand name of the drug that's being prescribed, and what's the generic name? And I'll show you some examples in a second. And then what is the dose of the medication, and what are the directions or frequency of that medication? Oh, I didn't give an example. So let me give you an example. Medication is Ramipril. So Ramipril is medication used for blood pressure and for heart failure and atherosclerosis. So usually given for blood pressure, but after a heart attack, we often prescribe it because it helps the healing and the maintenance of well-being of the lining of a blood vessel of the arteries, the endothelium, so endothelial health. And Ramipril is also useful for heart failure, improving the contractility of the heart. So it can be used for high blood pressure, coronary artery disease, or for heart failure. It can interact with other medications, some that are even over the counter. So it works through the kidney. If you take other medications that can affect the kidneys, like Motrin, ibuprofen, that can affect your blood pressure. They interact, they can cause additive effects on the kidneys to reduce your kidney function as well. So one brand name of Ramipril is Altace, but its generic name is Ramipril. So you can think of the brand name kind of like a given name, and the generic name is like the family name. When you look at your medications, you might see a prefix like mint. So that doesn't mean there's mint in the medication, and it doesn't mean it's mint flavored. That's the abbreviation for a generic drug company. So you can kind of ignore what comes before the hyphen after mint, and it's the name that comes after that will be the generic drug name. APO is another prefix which represents a generic drug company that makes the medications, but it's what comes after the prefix, after the APO, which is the name of the drug. So try not to memorize just those first 3 or 4 letters of your drug, because that's the generic drug manufacturer, not the actual drug itself. You need to know the dose of the medication. In the case of Ramipril or Altace, typically 2.5, 5, or 10 milligrams. And the frequency is how often you're supposed to take it. So most of the time it's taken once a day. In some cases, it's taken twice a day. So those are the key things, so that have that written down for any medications you've been prescribed. And at your fingertips, you should always have this, especially if you're a grown-up or if you're a kid with a complicated health background like myself. Number one, do you have any allergies to any drugs in particular? To things like IV contrast or adhesives that are used in medical purposes? Or do you have allergies to food? So those are important for you to know and have written down. And it's important to write these things down, like carry in a wallet or purse, so that if you're in an accident and couldn't speak, then that history is available for the emergency doctors or the paramedics. 2, do you have family history of serious medical problems such as premature heart disease? But now you'll be able to say if it is premature heart attack and at what age, if it was heart failure and at what age, if a family member has high cholesterol or diabetes, or certain types of cancers that are hereditary, like breast or colon cancer or prostate cancer. So family history, especially first degree relatives, your parents, and then second degree, like your grandparents, and definitely your siblings who are first degree relatives too. You should have at your fingertips the dates of hospitalizations and the reasons for those hospitalizations. Include the dates of any surgeries and the names of those surgeries or procedures. And of course, major illnesses like a stroke or heart attack, like being hospitalized for COVID or in the ICU. And then fourth, on your medical history summary, you should have chronic medical conditions such as high blood pressure or diabetes, or an underactive thyroid, hypothyroidism, or yeah, or coronary artery and heart failure. So those are key things to have there as well. And of course, a list of your medications that have those details. So the brand name and generic name. Generic name is most important. What it's for, the dose, and how frequently you take the medications. And these are kind of key questions when you're talking to a doctor. My patients don't have to ask me these questions, but some that have watched my talks will, in fun, ask me. So if you're worried that the strange doctor that doesn't really know you and doesn't treat you like their own family, if you're not sure that they got the diagnosis right or have the right plan, you can ask these key questions because it just makes the doctor start thinking about you as their own personal family practice patient, or like they would think about their best friend or own family member. So if you're not sure the diagnosis and the plan is right, then first question to ask is, what else could it be, doctor? Because we're trained to think about what's common, but we're also trained to think about what's the worst thing this could be. Like we want to rule out cancer or stroke or heart attack. We want to rule out the serious things, even though it might seem really obvious as most likely this common thing. So asking what else could it be? Because when you're talking to the doctor presenting symptoms, there are many possibilities that your symptoms might indicate different conditions. So in our minds, we're listening, we're asking key questions, trying to narrow this broad, what we call differential diagnosis. So it could be many things, and with more information, we can narrow it down to a few things. But sometimes when a doctor's in a rush, he or she might funnel down too quickly to a diagnosis and make it fit your symptoms. So sometimes it's helpful if that might have happened to ask your doctor, what else could it be? So it forces us to open up and think about it again. And again, ask that question, what's the worst thing could it be? Like ask, could it be cancer? Could this be a heart attack? And another to personalize yourself is, what would you recommend to your mother if the doctor is younger than you? Or what would you recommend to your own child if the doctor's older than you and your kid? Or what, yeah, so that kind of opens things up. So we remember that you are someone's parent or child or someone's best friend or something. So what else could it be, doctor? What's the worst thing it could be? And what would you recommend that your mother do, or what would you do? So remember the positive potential. We talked about disease, but the positive potential is taking what is, taking our risk factors, identifying things early, being proactive, working with healthcare providers and other people with the same condition, like a support group, so that you can achieve your best health, no matter the circumstances. So the heart is a muscle that improves with training. So we can't change our chronological age, but we can improve our physiologic age. So actually, kind of proven it to myself because I continue to train and swim every day. And my swim time today was faster than my swim time a year ago and 2 years ago. So this morning I completed my 80 lengths or 2K front crawl in 47 minutes. So that's better than I would have been able to do a year ago. And that's just pushing myself, but in a safe way. So the heart is a muscle that we can condition. So is your brain, not quite a muscle, but we can condition and learn new things and new approaches and new ways of thinking about ourselves and our worlds and our relationships to one another. And I really believe that health is not about treating all our problems, but seeing that positive potential. So when we have a problem, I like to turn it into a goal. So what is your positive potential? What's the positive potential of this situation? I believe that every one of us has a unique potential in life, or many potentials, and that's really your gift to the world, using your talents to make the world a better place. And it's our duty to realize that potential, to work towards it, but also importantly, to help others to discover their potential and achieve theirs too. That is part of an infinite game where we all win and benefit by each other's well-being. With knowledge, engagement, and support, we can manage chronic health conditions and live well, because we all have chronic condition. So the most common chronic condition, so everyone in the audience, including myself, has the same chronic condition. Bad news, it's incurable. It's sexually transmitted. It also has 100% mortality. I think you probably guessed that chronic condition is life. So let's make the most out of it. And please share what I've given to you today. You can review things, share the handouts, but I hope that things I've said today will lead to many lives saved. Recognizing conditions early, for you to take control of your health or helping your loved ones take control of their health as well. So that would make me super happy if we can all be healthier and live our potential and live longer and live really active lives with the people we love the most. So I'll stop my share. And I think I'm right on time, but we have time for any questions or comments you'd like to share.
Right. So I'm back. So we do have a couple of questions in the chat here. This first one says, my husband has bradycardia. His last blood pressure reading was 104, 51, 48. He is 90, has had these kind of readings for over 30 years, and yet is fine. Can you explain this? Excuse
Yeah,
me. His
so
internist isn't worried, but doesn't have an explanation either. Thanks.
yeah, could you read the numbers again so I can explain it to people?
Sure. 104, 51, 48.
Okay, so 48 was the heart rate. And the first two numbers were the systolic blood pressure and diastolic blood pressure. So if those numbers aren't causing lightheadedness, those are lower than average blood pressures, but those would be perfectly fine if someone's not passing out or fainting. And you can have a slower heart rate as long as you're getting blood to your organs. So that they must have had done electrocardiograms and Holter monitors to show that the conduction in the heart is normal, and probably did echocardiograms to show that the heart function is normal. So yeah, there's nothing wrong with those numbers. So at night, my heart rate can go down to the low 40s, and then it rests around 50, 48 to 50. So that's considered bradycardia, but it could be perfectly fine. Yeah, so any other questions?
Yeah. So regarding risk factors, when talking about smoking, does that only include cigarette smoke or all kinds, i.e., vaping, smoking marijuana?
Well, cigarette smoke, because the tobacco has particularly noxious effects on the heart muscle. So it's not so much the nicotine, which is the addictive part, but it's what you're inhaling from all the tobacco, the rest of the tobacco. We don't know too much about the effect of cannabis from the smoking part on the lungs and the arteries. So we'll probably learn more over time. And vaping, we don't know what the damage is of the other chemicals that are being inhaled at that time as well.
Right. Okay. Next question. If you have creases on your earlobes, are you more at risk for something to go wrong with your heart?
That's actually from Chinese medicine. So in traditional Chinese medicine, the patient didn't undress. So they actually checked the pulse, looked at someone's face, looked at the ear, as if it's like a version of the body turned upside down. But the particular thing about the creases actually has some merit to it. So creases in the earlobe kind of reflect elasticity, your connective tissue. So if there's a problem with the elasticity within the arteries and you got really wrinkly earlobes, it's sometimes can be correlated with um, the health of your blood vessels as well. So some correlation there, but probably not enough to worry about. But of course, you've got wrinkly earlobes and you have family members that died from the different forms of heart disease, like heart failure or heart attacks. Then it gives you a clue to look a bit further.
That is fascinating. Thank you. How do I know, sorry, how do I know that my arteries are narrowing down? Can I ask for some kind of test to find out for prevention?
Um, if you're 16 and you can run like really fast, heart rate goes up to 205 and you don't get any chest pain, no shortness of breath, and no one in your family has died from suddenly, unexpectedly, and no heart attacks or angina, your risk could be really low. If you're 50 years old and family members have had heart disease, um, and you have some risk factors, you can't decide if you should be on a cholesterol-lowering medication, your blood pressure's under control. So there's a possibility you could have heart disease. So there is something, a private test you can do called the calcium score. And you can get a private CT that gives a score of the calcium that's in your heart and tells you if you're increased risk or not. You could do private scans like the CT angiogram, which actually shows the blood vessels and shows narrowing without having to snake anything into your arteries. So when we order a CT angiogram, I believe it's a long wait, can only be ordered by a cardiologist through the public system, but people can pay for that privately as well at private clinics. And that sometimes people use that to determine the risk factors if they should be on a cholesterol-lowering medication, for example. Yeah, but the rest of us, family history is a big key, and also looking for some of those symptoms like typical angina symptoms that we described, or the atypical angina symptoms like shortness of breath or nausea with activity or exercise.
That's great. Thank you so much. Is aquasize a good and safe exercise?
Um, I believe so. I haven't seen too many injuries in people doing aquasize. A lot of my patients do aquasize, so it tends to be low impact. I guess if you can't swim, it could be a bit dangerous. If you didn't have a good instructor that kept people far apart so they don't hit each other with noodles. My patient that loves aquasize today told me that they have this new elastic bands they're using. I said, that sounds dangerous. You'd have to wear your goggles so you don't get your eye hurt by the elastic band, but he says they're quite far apart. So most of the time, supervised aquafit class is very safe in a Burnaby pool, for example.
Right. Good plug. Good plug. So I'd like to welcome actually in the audience today, we've got Masood Rahmani, who's one of our staff members, a PCN staff member. So he loves our talks. He's a good fan of the talks. So he does have recommendation. He does a lot of work in community under the PCN. And so just a question around getting these talks translated. So we'll take that offline and see if we can come up with an answer to that one, or a strategy. Question from Masood is, do you advise taking a coated small dose of aspirin daily after the age of 40 to prevent cardiovascular disease? There's a common belief amongst the public that this practice can help in preventing heart-related conditions. Thanks.
So the average person should not be taking aspirin unless recommended by a doctor. So people that are increased risk for heart disease, like people that have had a heart attack or a stroke, will be told by their treating physicians that they should probably be taking an aspirin or other blood thinner. But for other people that don't have those risk factors, then your risk for getting a gastrointestinal bleed, an ulcer, is more likely than the heart attack. So we don't recommend that baby aspirin. Um, if you think you're having a heart attack, that's when people are told that they should chew 2 baby aspirins. By the way, you should never give aspirin to babies, but 81 milligrams is a quarter of the standard 325 milligram aspirin. Yeah, and don't use a regular aspirin for your aches and pains because that could again increase your risk for bleeding, but also getting an ulcer as well.
Oh, yikes. Okay. Thank you. Question is eating instant noodles and macaroni and cheese regularly bad for my heart artery? And will that lead to more stroke and heart disease?
We got to read the label. So often, most of those packaged foods like the instant noodles and Kraft Dinner are a little bit higher in sodium. So that salt, for some people, might contribute to high blood pressure. People with low blood pressure and feeling lightheaded frequently, we often actually recommend eating more salty things. as long as we don't end up with high blood pressure and their kidney function is good and they don't have heart failure. You have to look at the labels for saturated fats, especially if someone does have heart disease or high cholesterol. Then you want to limit the saturated fats. So read the labels. Once in a while as a treat is fine. What we eat every day. So if you're eating that every day, it'd be kind of like that diet for the guy that made the documentary where eating McDonald's food 3 times a day.
Yeah.
So yeah, I don't think it'd be healthy to eat macaroni and cheese 3 times a day or instant noodles all the time.
Not great. Not great. Question. Do I have damaged and expanded left ventricle if I have heavy chest pain or my chest feels like a huge load on it?
Well, we don't know until you see your doctor do an echocardiogram.
Right.
Sometimes we can actually see just in a chest X-ray if the cardiac silhouette is enlarged. We can often tell examining the chest if the heart is enlarged, just where the pulse is, and for palpation. But the symptoms, suggest that you definitely need to be checked out.
Right. And I think this incident, this happened for this person. They had had a fall. So it was something a post a fall. So we got a little bit more into some details here, but we've gone a little bit over time. Is it
Definitely
vegan? Oh,
yeah, definitely if it's next to when a piano fell on your chest, you probably still have something really big pressing on your chest.
is a vegan diet better than a non-vegetarian diet for the heart?
Definitely can be. So you can depending on how you're cooking things, because if you're using a lot of creamy things that are higher in cholesterol, that may not be so good. But generally avoiding the saturated fats that we get from red meat, beef, lamb, and pork. I always say beef, lamb, and pork instead of red meat to my patients because they think that pork is white meat. Where, yeah, yeah, you should watch videos of people that have pigs for pets, and you can see just how human and smart they are. They're so human that we actually use uh, pig tissue for heart valves, so they won't get rejected by our genetics. So those porcine valves, we don't even need to use blood thinners for people that have a porcine valve. It's not a porcelain valve, it's actually pork-derived valves. So anything from a pig is fatty, except maybe the heart valve. But pretty well everything else from a pig is not healthy for us. So a vegan, vegetarian diet, definitely healthier. Having that fish though, so if you're a little bit more lenient, like my son eats lots of fish. So fish have a lot of, especially the fatty fish, have a lot of healthy fats that raise the good cholesterol, so they are really protective. I recommend more like a diet like the Mediterranean diet. And if you do have meat, maybe aim towards lean white meat or maybe fish. And definitely half of our plate should be vegetables. We'll be talking a lot
Yeah.
about the Canada Food Guide, the diet for diabetes, diet for heart disease, risks and benefits of intermittent fasting and other trendy diets. So that'll be our next talk, like exactly a month from now.
Yeah, that's a perfect segue. And I did pop the registration link into the chat again, just as you were finishing up. So if folks want to register for that, it'll be off your to-do list and we will see you in a month. I had some thank yous here. And how can an asthmatic person differentiate between an asthma attack or if the tightness in chest is due to a heart problem?
Yeah, so typically asthma can cause wheezing, but even we sometimes hear wheezing if someone is in heart failure as well. Using your bronchodilator Ventolin would give you immediate relief, at least temporary, for the wheezing and tightness in the chest. So that's a clue. People that are known to have angina will take a medication called nitroglycerin. Typically, it was pills under the tongue, but now we use nitroglycerin spray. And nitroglycerin dilates blood vessels. So if you're having angina, it dilates the blood vessels, it relieves the angina. So that's one of the diagnostic clues that the squeezing chest pain is actually from narrowing of the arteries, at least temporarily.
Great. And I guess we'll make this the last question. It's a two-part here. If you have a cholesterol level that has increased since you were 65 and is now moderate, and the LDL is above average, family history of heart attacks, now on Robitussin, try is still a little high. Would the doctor be able to order more testing and review the heart blood work before 1 year as suggested? Can people go off the medication if levels improve?
Well, usually when my patient has high cholesterol and like high enough so that we want the target is to get that LDL cholesterol lower and improve the ratio between the bad and the good cholesterol. We usually try the diet first unless it's crazy high, like triglycerides that are so high that they can inflame the pancreas and cause hospitalization. But if they're not that acute, we usually try like strict diet first, at least diet that they can tolerate. And if it's not improved, then we offer the statin. If the person is already on a good diet and the cholesterol is really well controlled and not overly decreased, if they're just meeting the targets, they probably should stay on the medications unless they're having side effects. Of course, if it goes really low, they could probably lower the dose. But if someone requires cholesterol lowering medication, if they have side effects, there's some newer cholesterol medications that are available with special authority. Often we will send people to the lipid clinics if the standard medications aren't controlling it or controlling the cholesterol.
Right. Thank you. Well, that's it. So we had some nice thank yous in the pop up in the chat that you can see. And we went a little over, but it was really important information, all sort of summarized in a short period of time. And again, there's the resources on the website for folks to visit. So I think we did it. Well, you did it.
It's teamwork, and thanks for all your being here. And please share information with your loved ones. And I hope
Mhm.
something I've sent today can prevent a broken heart.
That's right.
And I hope no one has a broken heart tomorrow. But I think the key is
Yes.
to lower your expectations.
It's a good plan. That's a good plan. Excellent. Well, I think we did it. So, like I said, when I close down the our session today, an evaluation is going to pop up. So, if you wouldn't mind filling that out, Dr. Wong and I do review those every time. So we appreciate it, and hopefully we'll see you next time.
Great. Thank you. Thanks, Leona, and thanks
Thanks,
all of you for
everybody.
being
Thanks,
here.
Dr. Wong.
Yeah.
Good night.
Happy Valentine's.
Happy Valentine's Day.